Yes, okay. So after discussing and finishing the retinoblastoma, we will take on Snellen's chart. We'll take on Snellen's chart. This is how patient is checked for far vision. This is Snell's chart is for far vision. Okay. You must have, all of you have seen this chart in OPDs. So the name is called as Snellen's chart. Okay. Now, suppose this is the chart, and if the patient is able to read this topmost letter, if the patient is able to read, just try to understand the concept. If the patient is able to read this top letter, vision is 6/60. And if the lowermost letter is the patient is able to read, vision is 6/6. 6/6. Now write down the principle behind this Snellen's chart. Write down the principle behind this Snellen's chart. This each letter in the Snellen's chart subtends an angle of 5 minutes. Subtends an angle of 5 minutes at the nodal point of eye when it is viewed from its respective distance. When it is viewed from its respective distance. And now you will tell me which type of cataract was present at the nodal point of eyeball, which was causing maximum visual disability to the patient. Answer me in the chat box which type of cataract is present at the nodal point of eyeball, which was causing maximum loss of vision or maximum visual disability. Answer me. Answer in the chat box, please. Posterior subcapsular cataract, right? Good. So the principle behind the Snellen's chart is that each letter subtends an angle of 5 minutes. Here, this 5 minutes is important. It subtends an angle of 5 minutes at the nodal point of eyeball. Okay. Now, if the patient is illiterate, if the patient is illiterate and he cannot read the alphabets, then write down vision testing in illiterate patients. So which chart we use for illiterate patients? The name is called as Landort's C-ring test. Landort C-ring test. It looks like this. Letter C is made in different directions, and we ask the patient in which is open, right? So Landort C-ring test is a test for vision testing in illiterate patients. The name of another chart is Snellen's E-chart test. Snellen's E-chart test. Snellen's E-chart test. Now, if you want to test for near vision, the name of the chart is called as Jaggers chart. It is called as Jaggers chart. Okay. Now, one of the physiological insufficiency of accommodation we have discussed. Can you please tell me the name of that physiological insufficiency? Physiological insufficiency of accommodation. The name of that physiological insufficiency was? Answer me in the chat box, please. Presbyopia. Which type of glasses we were prescribing in presbyopia? Plus glasses or minus glasses? Plus glasses or minus glasses we were prescribing? convex. Yes, convex are the plus glasses and concave are the minus glasses. Now, one thing which is important for your exam point of view, you have to differentiate between convex glasses and concave glasses. So there are some tactics which you should know how to differentiate between convex glasses and convex lens and concave lens. So write down types of lenses. Heading is types of lens. The first one which we will discuss is your convex lens, and the other one is your concave lens. Remember, these convex lenses, they are the converging lenses. Whereas these concave lenses, they are your diverging lenses. So as you know that these are your plus lenses, and these concave are your minus lenses. Okay. Now, if in the practical examination, the examiner gives you two lenses, how you will identify which one is convex and which one is concave, right? It is not written. Suppose they have hidden the plus and minus. Then without seeing whether it is plus or minus, how will you differentiate? Write down. Identification of convex and concave lenses. So these convex lenses, they are thick in center, whereas concave lenses, they are thick at periphery. Now, how you can remember one important point? Write down important question. Because convex lenses are plus lenses, so these plus lenses, through these plus lenses, if you see an object, that object appears magnified. Okay, magnified than normal. Because how you will remember that convex is magnified? Because convex is plus, so it will magnify. Whereas concave is minus, so that is why the object appears minified. Minus will reduce, it will decrease the size of the image. So object appears minified in concave lenses. Clear? Very important point, differentiating point between the two lenses. This convex lenses, write down the uses. It is used for correction of hypermetropia, whereas concave is used for correction of myopia. Okay. Now write down. Heading is refractive error. What is the classification of refractive error? How many types of refractive error are there? The one is E-metropia, means no refractive error. This is not. Whereas ametropia means some amount of refractive error is present. This ametropia is divided into three types of refractive error. One is myopia, as you all know. Other one is hypermetropia, and the third one is astigmatism. Now you will tell me, what is the size of axial length? What is the size of eyeball in hypermetropia? Is it small or it is large in hypermetropia? Big in myopia, right? Big in myopia, small in hypermetropia, right? And when the axial length is more than 26, when the axial length of the patient is more than 26 millimeters, the patient is pathological myopia. Patient is having pathological myopia. Clear? Pathological myopia, where we have studied, it is a cause of pathological myopia. It is a cause of, we have discussed in retina, pathological myopia, cause of, no, senile cataract, no. Pathological myopia, it is a cause of which type of retinal detachment? Rhegmatogenous RD, right? Rhegmatogenous RD. Okay, good. Yes. So now we will take on myopia first. Write down. In myopia, as you all know, the image is focused. Image is focused in front of retina. Image is formed in front of retina with accommodation being at rest. Talking about types of myopia, first we will discuss axial myopia. Axial means the axial length of eye. If there is 1 millimeter increase in the axial length of the eye, it will give you, or it will induce 3 diopters of myopia. This is important question. 1 millimeter change in axial length will give you 3 diopters of myopia. Okay. Next is curvature, means the curvature of the cornea or lens changes. Curvature of lens or cornea changes. So if there is 1 millimeter decrease in the curvature of lens or cornea, it will induce 6 diopters of myopia. 6 diopters of myopia. Third, positional myopia. So what happens in positional myopia? The position, it depends on the position of your lens. If your lens moves anteriorly, then it will induce myopia. Your index myopia, which we have discussed in cataract, in nuclear cataract, second sight phenomenon, you remember, in which your refractive index, RI is refractive index of lens, increases. So when refractive index of the lens increases because of hardening, it will induce myopia. It will induce myopia. So one of you have asked me, what is presbyopia? Presbyopia is a phenomenon. It is a problem with accommodation. It is a problem of accommodation. So it is a physiological process. As we age and we reach about age of 40, our accommodative power of the ciliary body decreases, right? So when accommodative power of ciliary body decreases, automatically what will happen? Ciliary body accommodation is responsible for which type of vision? Near vision, right? So when accommodation decreases, your near vision is hampered, right? And that is called as presbyopia. And for correction of presbyopia, you will need convex lenses, which are plus lenses. Okay? Wait, you just wait. Hold on. What is called when image fall behind, we'll discuss. Right? So these were the classification of myopia. Okay? These were the classifications of myopia. Now coming to hypermetropia. Hypermetropia. metropia. When the light rays are focused behind the retina, it is called as hypermetropia. Hypermetropia. Again, it has these are four types of hypermetropia. Is axial hypermetropia, when axial length of eyeball changes with 1 millimeter decrease, it decreases 3 diopters. It gives you 3 diopters of hypermetropia. 1 millimeter decrease of axial length gives you 3 diopters of hypermetropia. Second is curvatural hypermetropia, when your curvature of cornea or lens decreases. The values are not important for your exam in curvature hypermetropia. Talking about positional hypermetropia, when your lens, biconvex normal lens, moves posteriorly towards posterior segment, that induces hypermetropia. And fourth type is index myopia. Index myopia occurs when the refractive index of lens decreases. When refractive index of lens decreases, then it induces hypermetropia. Okay. Now coming to astigmatism. Astigmatism. What is astigmatism? Write down the definition. The refraction varies in different meridians. The refraction varies in different meridians of eye, due to which, because of different meridians of eye, the refraction varies, due to which light rays fail to focus. They fail to focus at a point. Suppose this is your principal axis, your object. This is your lens. This is your retina. Now suppose parallel rays of light are coming like this. Now there is refraction at the corneal surface. There is refraction at the lenticular surface, lens. But instead of focusing at a point, they don't focus at a single point. Okay, single point focus. So that will give you astigmatism. Now talking about the types of astigmatism, write down the classification. It is of two types: regular astigmatism and irregular astigmatism. Now suppose this is your cornea, right? This is your cornea. It is having two surfaces or two meridians are there. This one is vertical meridian and this is horizontal meridian, V and H. Vertical meridian and horizontal meridian. Okay. The treatment we have already discussed. Myopia, we prescribe minus glasses. Hypermetropia, we prescribe plus glasses. In myopia, we prescribe minus glasses, concave, minus glasses. In hypermetropia, we prescribe plus glasses, which are the convex glasses. In astigmatism, coming back to astigmatism, this cornea has vertical meridian and horizontal meridian, right? So this is normal. So what is regular hypermetropia? Write down. There are two types of hypermetropia, regular and irregular. Write down regular. There are two principal meridians. There are two principal meridians. Two principal meridians are present, and they are so two meridians are present, horizontal and vertical, and each other. Then that is called as regular astigmatism. And if the two meridians, are not perpendicular to each other, they are, then that is called as irregular astigmatism. That is called as irregular astigmatism. So normally we have two principal meridians. That is normal, okay? Vertical meridian is there and horizontal, and both are perpendicular to each other. So that will give you a regular type of astigmatism. Now this regular astigmatism is of three types. First one is called as with the rule astigmatism. With the rule astigmatism. Second is against the rule astigmatism. And third is oblique astigmatism. Now, from your exam point of view, these two are important. With the rule and against the rule astigmatism. Suppose this is your corneal curvature. This is your cornea, in which if your vertical meridian, this one is vertical, right? So if vertical meridian is more curved as compared to horizontal meridian, if vertical meridian is more curved as compared to horizontal meridian, then that gives you with the rule astigmatism. So vertical meridian is more curved in with the rule astigmatism, whereas in against the rule astigmatism, cornea will be like this, in which horizontal meridian is more curved than your vertical meridian. So that will induce against the rule astigmatism. Whereas this oblique astigmatism, write down, the two principal meridians are there. The two principal meridians, they are not perpendicular. They are not horizontal and vertical. Not horizontal and vertical, then it will give you oblique astigmatism. For your exam point of view, remember these two types: with the rule astigmatism, against the rule. If vertical is more curved, then it will give you with the rule. If horizontal curvature is more curved, horizontal meridian, then that will give you against the rule astigmatism. Okay. Now talking about the treatment of astigmatism, you prescribe cylindrical spectacles or toric lenses. Cylindrical or toric lenses are prescribed in astigmatism. Cylindrical or toric lenses are prescribed. Okay. Now next, Topic write down. Amblyopia. What is amblyopia? In layman term, it is also called as lazy eye. It is also called as lazy eye. It can be unilateral or it can be bilateral, but usually it is unilateral. Unilateral or bilateral partial loss of vision without any organic cause. Without any organic cause, then that is called as amblyopia. Cylindrical lenses and toric lenses. Classification is important. Only two things you have to remember: with the rule astigmatism and against the rule astigmatism. So in with the rule, your vertical meridian is more curved, and it is opposite case in the against the rule astigmatism. So now I'm telling you another important concept of amblyopia. So what happens? This is seen in children's. This is usually seen in children's amblyopia, lazy eye. What happens? The child present to you with loss of vision, which is 90% of cases it is seen unilaterally. Suppose my right eye child is 5 years of age, and the vision of the child is 6/12. The patient is not able to read the lower two lines. Okay, whereas the other eye is 6/6, normal eye. Now I have examined the anterior segment of the eye. Eyeball is okay. I have examined the retina. That is also okay. There is no pathology in the eye, but still patient is reading two lines less than normal. Okay, what can be the cause? What can be the cause then? So there is no organic cause of loss of vision, but still the patient is having loss of vision. What can be the probability? What are the chances you think? See, in newborn child or children, what happens? My suppose right eye is not working properly. It has become lazy. So both the eyes have very good coordination. Both the eyes have very good chemistry, right? So if my right eye is not seeing properly, it has become lazy. My left eye will overwork for my right eye. Okay, so it will work more. It will try to focus more. It will see more. Okay, so it will compensate for the loss of my right eye. Understood? So that is why, because I am seeing okay, I am seeing the objects, my work is fine, because my left eye is overworking, overpowering the right eye. And right eye is slowly and slowly has become lazy now. Understood? So that is why, this eye is going lazy. Understood? Now, if I close this eye, my right eye, which has become lazy, will not be able to see the normal vision. Vision will be decreased in this eye. Whereas if I uncover the other eye, my vision, I will be able to see properly. So that means both eyes have good chemistry. The other eye is overpowering and working for the other eye. Okay. So this eye has become lazy. Now, can you tell me what is the treatment? What I will do so that my this eye, which is not working properly, it has become lazy. So what should I do so that it start working? Right. Yes. So I should, if I patch this eye, which is overworking, and overpowering the other eye, what will happen? My lazy eye will be forced to see the objects, right? My normal lazy eye will be forced to see the objects. Okay. So that is called as patching. So you have to remember that the patching is done for normal eye or amblyopic eye. Patching is done for normal eye, which is seeing 6/6. Okay. Problem is present in lazy eye. So it is not working because the other eye is working for it. So if I patch this normal eye, left eye, obviously then if this is not seeing now, I have patched this eye. So my right eye will be forced to see on objects, and gradually and gradually my vision will be regained in lazy eye also. Understood? Understood the problem? So you have to understand that the patching is done in normal eye. Okay. Now write down in amblyopia. Write down treatment. Treatment, write down amblyopia. Amblyopia develops. Amblyopia usually develops within 6 to 7 years of life. So, treatment is advised ASAP, as soon as possible. And what is the treatment? We go for occlusion therapy. Occlusion therapy. Important question. Is occluded. Normal eye is occluded using a cotton pad or patch, okay, to allow amblyoptic eye to fixate on objects. So my amblyoptic eye will be forced to see the objects because I have covered the normal eye. Okay. Now you will tell me for how many days I will patch the normal eye. For how many days I will patch? I will patch the normal eye permanently. If I do so, my normal eye will become amblyopic after a few times, after a few months. So, for how many days patching is done for normal eye? So, there is a formula which you should remember for how many days patching is done or occlusion is done. Write down. So, occlusion of normal eye is done for X number of days, where X is the age of child, where X is the age of the child, followed by occlusion of amblyopic eye for 1 day. Followed by 1 day. Now I'll give you example. Suppose a child comes to you, his age is 5 years, he is amblyopic in the right eye and left eye is normal. So I will patch the normal eye, not the amblyopic eye. I will start the patching with the normal eye. For how many days I will patch? He is 5 years old, so I will patch for 5 days. Okay. After 5 days, I will advise the patient to patch the amblyopic eye for how many days? For 1 day. After 1 day, repeat. After 1 day, 5 days for this 1 day, 5 day, 1 day. Understood the concept? Give me a thumbs up if it is clear. So it shows very good results. Patching is in children is very prognosis is very good. So important question which they give to confuse you is that they will ask you that patching is done in which eye? Then answer is that patching is done in normal eye or amblyopic eye. It is done in, tell me the chat box. Patching is done in which eye? Normal eye, right. So can you tell me this KF ring, what is the location of the cuprocyan deposition? In which layer of cornea it is deposited? KF ring. Case of Fleischer ring seen in Wilson's disease. Which layer? Periphery, right. Which layer of cornea is involved? Desmet, sure. Desmet, are you sure? Okay. Now, can you tell me which type of culture media is used to diagnose acanthamoeba? This is a ring abscess. Ring abscess. Now tell me which type of culture media is used. Non-nutrient agar, enriched with E. coli. Good. Now next important topic is, which all of you have gone through, write down. We'll discuss conjunctivitis, right? So two important findings in conjunctivitis, just see the picture. Can you see, if you first see this conjunctiva? Okay. Can you see my eye? Can you see the white part sclera which is exposed? Which is exposed, white sclera? This white sclera is covered with the conjunctiva. Which conjunctiva is it is? The sclera, this which you are seeing, it is covered with a thin membrane which is called as conjunctiva. This thin conjunctiva which you can see is called as bulbar conjunctiva. This is your which conjunctiva? Bulbar conjunctiva. The conjunctiva which you are seeing like in front over the sclera is your bulbar conjunctiva. Give me a thumbs up if it is clear. Bulbar conjunctiva location, this one, the sclera. Over the sclera which you can see, white sclera, yes, okay. So this is your bulbar conjunctiva, one thing. If you evert your lower lid, and in the periphery, in this fornices, the conjunctiva which is present, that is called your fornicial conjunctiva. That is your fornicial conjunctiva. Okay, just understand. And if you evert my upper lid, the conjunctiva which is present on the tarsal plate, that is called as palpebral conjunctiva. That is your palpebral conjunctiva. Okay. If you evert your upper lid, the conjunctiva which is present on the tarsal plate, that is called your palpebral conjunctiva. Give me a thumbs up if it is clear. Three conjunctivas: bulbar conjunctiva, fornicial conjunctiva, palpebral conjunctiva. Palpebral means when you evert the upper lid. Yes. So when you evert the upper lid, palpebral, the one which you are seeing over the sclera, that is your bulbar conjunctiva. And in the fornices, these joints, this one, that is your fornicial conjunctiva. So can you see these follicles? These raised white dots are called as follicles. They are more elevated. They are whitish nodules filled with lymphocytes, and they are avascular. Okay. They are mostly commonly seen in viral conjunctivitis. And this one is papillae. Can you see this? These one. These are less elevated, but they are vascular. So these are papillae. So this is the basic difference between papillae and follicles. Okay. Now write down. Now write down. Yes, Sago-grain and trachoma also. Correct. Correct. Now write down important point about viral conjunctivitis. Write down viral conjunctivitis. Write down. Most common cause of viral conjunctivitis is adenovirus. Adenovirus. It causes preauricular lymphadenopathy. Lymphadenopathy is associated with viral conjunctivitis. Okay, clear? So if lymphadenopathy is there, preauricular, it is associated with adenoviral conjunctivitis. Adenoviral conjunctivitis. Can you see this excoriation? Can you see this excoriation is present? Now, if you see, there are two canthi. This one is this junction. Can you see this junction? This one, this point. This is called as lateral canthi. This is called as lateral canthi. And this one towards my nose, this is called as medial canthi. Lateral canthi, medial canthi. So next important point, write down. Next important question. Angular conjunctivitis. Angular conjunctivitis. You will see excoriation at the lateral canthus. You will see excoriation is present at the lateral canthus. Now, question which is asked is, it is caused by angular conjunctivitis is caused by Moraxella lacunata. Moraxella lacunata. Okay. Now, next important question which is asked is on treatment. First, write down what you give. Oxytetracycline eye ointment. And if they ask you which is the drug of choice, question is asked on this one. Drug of choice, then answer will be 2% zinc oxide skin lotion is given. 2% zinc oxide skin lotion is given. Next important question, write down. If they ask you most common cause of neonatal conjunctivitis, most common cause of neonatal conjunctivitis, answer will be chlamydial conjunctivitis. Chlamydial conjunctivitis. Next important question, if they ask you most common cause of neonatal blindness, then answer will be gonococcal conjunctivitis. Gonococcal conjunctivitis. Okay. So 3 questions you have to remember. Drug of choice for angular, zinc oxide, skin lotion. And these 2 questions, most common cause of neonatal conjunctivitis and neonatal blindness. Now, next important, very, very important question. Trachoma. So write down trachoma. Next heading is trachoma. Trachoma. It is most common cause of trachoma. Write down. It is chlamydia trachomatis, as the name says, trachomatis. So chlamydia trachomatis causes trachoma. Now you have to remember the serotypes also. Chlamydia trachomatis serotypes A, B, BA, and C. This is transmitted. This is transmitted by fingers and flies. Fingers, fomites, and flies. Now, another important question in trachoma is that there is a classification which is called as WHO's FISTO staging is there of trachoma. FISTO, where F stands for FISTO, where F stands for presence of follicles, which I showed you in the image. Follicles, I for intense inflammation, S for scarring, T for trichiasis, and O for opacity, corneal opacity. Trichiasis is misdirected, write down, misdirected eyelashes. So FISTO classification or staging you have to remember. Next important finding which is seen in trachoma is, write down, Herbert follicles. Herbert follicles. Herbert follicles, they are present at which conjunctiva? Bulbar conjunctiva. Bulbar conjunctiva. This Herbert follicle, if they ask you which is the pathognomic sign of trachoma, answer will be Herbert follicle. So these are pathognomic trachoma. Next important sign after Herbert follicles is boiled sago grain appearance. Boiled sago grain appearance of follicles. Boiled sago grain appearance of follicles. Important questions, both are very, very important. So these are the Herbert pits. Can you see, appreciate at the limbus? Now this is called as Art's line. Can you see a scarring is there? Scarring is there. If I invert the eyelid, upper eyelid, a scarred line is present. Can you tell me at which conjunctiva is present at this location? Which conjunctiva is present at this location? If I invert my upper eyelid, bulbar, no. Bulbar is what you are seeing on the sclera, this one. Palpebral, right. Palpebral, right. Okay. Good. So, previous slide. Sago grain and Herbert follicles we have studied. Very important. Now, write down next important line. One scarring white line, or scar at which conjunctiva? palpebral conjunctiva, palpebral conjunctiva of upper lid gives you a line which is called as arch line. Very important question. Arch line is seen in trachoma. It is similar. Arch line we have studied arch triangle also. Where we have studied arch triangle? Sir, in loss of vision, will the perception of light present? No. In loss of vision yes, loss of vision, patient will see, but he will not be 6 by 6. 100% he will not be seen. If the patient is blind, then perception of light will be absent. If the patient is blind, then the perception of light will be absent. So arch triangle we have studied in anterior uveitis, right? Mutton fat KPs, you remember? Keratic precipitates were there. Distribution with apex pointing upwards. So here is the arch line which is seen in trachoma at the palpebral conjunctiva. Okay. So these things you have to remember. Now next, write down. If they ask you to write down question, most common infectious cause of preventable blindness. If they ask you which is the most common infectious cause of preventable blindness, then answer will be trachoma. Why there is getting blindness? Because physto, last stage is opacity, corneal opacity. So cornea will become totally opacified and the patient can become blind also. Okay. Now next, write down WHO safe strategy. WHO's safe strategy for trachoma. So the treatment. So safe, you have to remember safe strategy, where S stands for surgery, A stands for antibiotic. Which antibiotic? The question is asked on antibiotic. They will ask you drug of choice for trachoma. Then answer is which antibiotic is given? Azithromycin, 1 gram, single oral dose, 1 gram is given. Important question. F stands for face washing. The patient is advised for facial cleanliness. And E stands for maintain hygiene, environmental cleanliness is to be maintained. So out of safe strategy, WHO question is asked on drug of choice for trachoma, and answer is azithromycin, 1 gram, single oral dose is prescribed to the patient. Okay. Yes. Now next topic is vernal keratoconjunctivitis, VKC. Vernal keratoconjunctivitis, it is also known as spring catarrh. It is also known as spring catarrh. That is why it is IgE cell mediated. It is IgE cell mediated. Okay. It is more commonly seen in young boys, more commonly presents in young boys presents in bilateral eyes, both eyes. Okay. Of VKC, patient presents with intense itching is present. Okay. And the type of discharge which is seen is ropey discharge. So this is a clue which is given in question. If this word is given in the history that the patient is having intense itching, young boy with ropey discharge, your answer is VKC. Your answer is VKC. This is a clue. Right? Now talking about signs of VKC. Signs of VKC. So first important sign is Horner-Trenta's spots. Horner-Trenta's spots or dots. Right? So these are the picture of Horner-Trenta spots. Can you appreciate these Horner-Trenta spots in VKC at the limbus? What is the location? They are present at the limbus. So location is also important. Location, limbus. Okay. Next important sign is your cobblestone papillae. So cobblestone papillae, very, very important. Horner-Trenta spots are very important. So these are present at the palpebral conjunctiva. They are present at the palpebral conjunctiva. Cobblestone papillae. They are very raised, big size papillae, which are seen if you invert the upper eyelid. If you invert the upper eyelid, can you see? Cobblestone papillae. They are giant shape, giant size, raised papillae. Okay. So these are seen at the palpebral conjunctiva. Horner-Trenta spots are seen at the limbus. So location is also important. Am I audible now? Am I audible? Okay. So location of these papillae are important. Papillae are present if you invert the lid, and you will see on the palpebral conjunctiva. Horner-Trenta spots are seen at the limbus. Very, very important. Okay. So you can't afford to miss these questions. Cobblestone papillae seen in VKC. Now, management is or treatment is also very, very important in VKC. Write down. First, write down. We give topical antihistamines. Topical. Second, we give mast cell stabilizer. Mast cell stabilizers are given. And the drug of choice for both is olopatadine, mast cell stabilizer, and topical antihistaminic. This is the drug of choice for VKC. Okay. Olopatadine. Olopatadine. It is the example of both antihistamine as well as mast cell stabilizer. So management is also important. Now coming to next topic. This is, you must be knowing, all of you, pterygium. This is a pterygium. Can you see a fibrovascular growth is encroaching over the cornea, right? And it is lying which direction? It is nasal or temporal? It is most commonly seen on nasal side. It is triangular shape, most commonly seen on nasal side, right? And you will see a slight yellowish line at the head. This line is called as, of the iron deposition, this line is called as Stocker's line. This line is called as Stocker's line, which is seen anterior to the head of the pterygium. Where is the head? This is the head. This one. This is the head of the pterygium. This is the neck. And this is the body. This is the body. This is neck. This is head. So what is the location of Stocker's line? What is the location of Stocker's line? Somewhere here. Anterior to the, it is somewhere anterior to the head of the pterygium. Okay. So Stocker's line, remember, this is a line seen anterior to the head of the pterygium, and there is iron deposition. Now this patient may present with corneal astigmatism. Okay, because the surface is irregular now, because of this pterygium, the refractive surface of the cornea becomes irregular. So the light rays will not be able to focus on a point object. So that is why it can induce, with the rule, astigmatism. Okay. Next important point about pterygium, write down. In the pterygium, write down. Pterygium, risk factors, write down. Risk factors of pterygium, write down. Sunlight, the most important one. Sunlight, smoking. Sunlight and smoking. Okay, so these are the two very, very important risk factors. Patients who are exposed to sunlight, they are more commonly prone to develop a pterygium. Okay, now coming to surgical treatment or management. So there is no medical management. You go for surgical excision. Surgical excision. First, you can just scrape the pterygium. You just scrape the pterygium. Shaving is done, and you can leave the sclera as it is. So that is called as bare sclera technique. Bare sclera technique. The problem with bare sclera technique is, write down, complication of bare sclera is that there are high chances of recurrence. There are high chances of recurrence in bare sclera technique. Now try to understand what is bare sclera technique. Now suppose there is pterygium. With the help of a blade, I will cut this pterygium. I will do the shaving, and I will clear the cornea. Okay, and I will cut the pterygium. I will not implant any graft over there. So that is the technique called as bare sclera technique. The problem with this technique is that there are high chances of recurrence of the pterygium if I don't implant any graft, conjunctival graft. If I don't implant, then high chances of recurrences are there. Okay. Second method is bare sclera technique with grafting. So in those cases, the recurrences chances are not there. Okay. So from where the graft is taken, write down. It is taken from the conjunctival limbal grafting. So from the limbus, we take the graft of the conjunctiva from the superior half, and we graft at the site of the pterygium. Okay. Clear? So if I plan to do surgery with grafting, so I will do shaving of the pterygium. I will cut the pterygium, and from the superior part of my conjunctiva at the limbus, I will measure this side. I will take a graft from the superior part of the conjunctiva, and I will paste that conjunctiva at the site of this pterygium. So in those operations, the chances of recurrences are very minimal. Got that? So what is the location of graft? Conjunctival limbal graft. From the limbus, they are taken off. Clear? Is that clear? Is it clear now? So this is pterygium. You have to remember the Stocker's line, and they can also ask you the deposition. What is the location of Stocker's line? Okay. What is the location of Stocker's line? So what is the location? It is just anterior to the head of the pterygium. It is just anterior to the head of the pterygium. All right. Any doubt in pterygium? Pterygium slide. Okay. This is the picture. It may present with corneal astigmatism. And the question has been asked on Stocker's line, which deposition is seen. That is also important. Iron deposition. It is not copper deposition. Please remember, copper deposition was present in KF ring. Copper deposition was present in KF ring. And in this Stocker's line, there is deposition of iron. Okay. So don't get confused. Ars line and ars triangle. Don't get confused. Right? Then there is Habstry and Vogstry. Don't get confused. Done? After corneal astigmatism, it is with the rule. Which type of corneal astigmatism is seen? With the rule astigmatism. With the rule astigmatism is seen. Not against the rule. With the rule astigmatism is seen. Done? With the rule astigmatism is seen in this pterygium. See, next important topic, write down. Can you see this swelling is there? This is very painful. Most of you have got this swelling also. This swelling is painful. Okay, this swelling is painful. And can you see this is present at the lid margin? This is present at the lid margin. It is called as sty. It is called as sty. Write down. Write down sty. The other name of sty, it is also called as external hordeolum. External hordeolum. Write down the definition. It is suppurative. It is suppurative inflammation of which gland? This name of the gland you have to remember. This can be asked in exam. This is suppurative inflammation of Z's gland. And the cause or the causative agent is Staph aureus. Staph aureus. Talking about clinical features, as I told you, this is painful, really painful. So you will get a swelling of the lid with pain, and there is a pus point is present at the lid margin. Okay, so this is present at the lid margin. This you have to remember. Pus point is present at the lid margin. Talking about treatment, patient is advised hot compression. Patient is advised hot compression plus topical plus systemic antibiotics. Okay. So Z's gland is important and location is at lid margin. This is also important. Done? Now this is another swelling. This is, can you appreciate this is away from your lid margin? This is away from your lid margin. This is called as chalazion. This is called as chalazion. Write down definition. This is lipogranulomatous. It is a lipogranulomatous inflammation of which gland? Again, the name of the gland you have to remember, important one. Meibomian gland. Important. This is non-infective. This is painless swelling and it is away from lid margin. It is away from lid margin. You have to do incision and IND is done. Incision and drainage is to be done. Clear? So these two swellings you must be able to differentiate the difference between chalazion and sty. Okay. Right. Sty always lower lid? No. Sty can be on upper lid also, but it is present at the lid margin. Can be upper or can be lower. Similarly, chalazion also, it can be on lower lid also. Okay. Next heading, write down optic atrophy. Optic atrophy. Optic atrophy. So when there is atrophy of a optic nerve, that is your optic atrophy. It is of three types: primary optic atrophy, secondary optic atrophy, and consecutive optic atrophy. Write down, if there is optic atrophy, optic A, optic atrophy without previous optic disc swelling, then that is called as primary optic atrophy. Talking about secondary optic atrophy, if is present after optic disc OD swelling, then that is called as secondary optic atrophy. If optic atrophy is due to, if it is due to disease of inner retinal layers and its blood supply, then that is called as consecutive optic atrophy. That is called as consecutive optic atrophy. So these are the three important optic atrophy that you should remember. Now, next important point in optic atrophy, write down, is about your optic disc appearance. So can you tell me where we have studied waxy pellar optic disc? Waxy pellar optic disc. In which pathology in retina we have discussed waxy pellar of optic disc? CRA or no? RP, right. Retinitis pigmentosa. Yes, good. Retinitis pigmentosa has this one. So talking about disc appearance, in primary you will get chalky white optic disc with well-defined margins. This is very important. Out of all the three, you just need to remember the appearance of primary optic atrophy. Chalky white. Secondary is not very important. Dirty gray white with ill-defined margins. And consecutive is also again important, which we have discussed. Waxy pellar optic disc. Clear? Now talking about causes of these optic atrophy, these are important. Primary optic atrophy, write down, number one cause and most important one is your optic neuritis. Optic neuritis. Then your tumor, trauma can give you primary optic atrophy. Hereditary. Toxicity, any toxic. Whereas secondary cause, write down, papilledema. papillitis, papilledema and papillitis. Consecutive, we have discussed this one, CR, AO, and RP, retinitis pigmentosa. Done. Of optic atrophy. Can you see the color of optic disc? It is chalky white. This is not normal, right? Normal color of optic disc was pale pink in color. What was the diameter? Vertical diameter of optic disc? Normal vertical diameter of optic disc was 0.3 was CD ratio. 1.5, right? It was 1.5 millimeters, right? What was the location of the macula? Macula was 3 millimeters temporal to the optic disc and slightly inferior to it. And the diameter of macula was 5.5 millimeters, right? So this is how your optic disc looks like in optic atrophy. Okay. Now coming to the next picture. What is this happening? Is it normal, the optic disc? So what are the changes you see in this optic disc? See, this is severely inflamed. This is more red. This is severely congested optic disc. Can you see the vessels are very tortuous? Blood vessels are tortuous. Can you appreciate that the disc margins are very blurred? They are not sharply demarcated, right? Congested vessels are there. And vessels are also tortuous. Can you appreciate these folds are there? These folds are called as Patton's line, and they are seen in papilledema. Papillae is here, papillae is optic disc, and edema is edema of the optic disc. Okay, so that is your papilledema. Papilledema. Now write down next topic, important, papilledema. Write down. It is always bilateral. Important question. It is bilateral, non-inflammatory, bilateral, non-inflammatory, painless swelling of optic nerve head. ON head is optic nerve head. But important point is that it is always and always secondary to raised intracranial pressure. Raised intracranial pressure. Okay. Condition is that it is always and always secondary to raised intracranial pressure. Talking about causes of papilledema. Causes of papilledema. Write down the mnemonic. Mnemonic is movies. Mnemonic for papilledema is movies, where M stands for malignant hypertension. HTN is hypertension. O stands for obstructive hydrocephalus. Obstructive hydrocephalus. V stands for venous sinus. Which venous sinus? Cavernous venous sinus thrombosis. I stands for idiopathic intracranial hypertension, which is called as pseudotumor cerebri. Idiopathic intracranial hypertension. And E stands for endocrinal cause, which is toxemia of pregnancy. Toxemia of pregnancy. Pregnancy was also the cause of which type of RD? Exudative RD. So here, movies you have to remember in papilledema. Movies. Important. Features of papilledema. First, we will discuss symptoms. Patient will have headache. This is the earliest symptom. This headache is associated with nausea and vomiting. And the characteristic of this vomiting is that it is projectile vomiting. Okay. Now, next clinical feature is that the patient has normal vision. Now, you will tell me why the patient is having normal vision in this condition, such problematic condition. Can you see this? So much of inflammation is there in optic nerve. So much of congestion is there. Still, the patient is having normal vision. Why? The reason is, tell me in the chat box, what do you think? Why the patient has normal vision in papilledema? Compensated. No, it is not compensated by other eye. Just think that it is a disease of optic disc. There is edema in the optic disc. Understood? And we have already discussed this concept I think 3-4 times we have discussed this about optic disc. Visual field we have discussed optic disc, because in posterior segment, no. Optic disc blind, right? Yes, very good. So optic disc we have already discussed that it is blind spot. There are no photoreceptors. So it is a blind spot. When optic disc is involved, it is already blind spot. No vision image is formed. That is why patient has normal vision. Understood? Give me a thumbs up if it is clear. Why a patient has normal vision in papilledema? Because optic disc is blind spot. Because optic disc is blind spot. Give me a thumbs up if it is clear. Okay. Good. So patient has normal vision. Okay. Next important point, patient can have Paton's line, which I showed you in the picture. Paton's line are retinal folds, retinal or Clear? Next, write down. Next important topic, write down. Horner's syndrome. Horner's syndrome. Horner's syndrome. The other name of Horner syndrome, write down, it is also known as oculosympathetic palsy. Now just think, other name is oculosympathetic palsy. So this means that sympathetic nervous system palsy is there. So obviously when sympathetic palsy is there, the parasympathetic nervous system must be activated, right? So all of the findings in the body which are governed by parasympathetic nervous system will be activated in Horner syndrome, right? So I'll give you all the answers in one mnemonic only. All the answers will be covered in one mnemonic only. No need to go in detail. Write down. It is dilator pupillae palsy. It is a dilator pupillae palsy. Okay. Now write down clinical features. And the mnemonic is high maple. Maple syrup, you all know. And high COPS was mnemonic for? High COPS was mnemonic for? Tell me. High COPS. Meiosis, meiosis, mydriasis. Meiosis was high COPS, right? And big oats was for mydriasis. Here in Horner syndrome, high maple syrup. So write down for H stands for hypochromic, and H stands for heterochromia iritis. Heterochromia iritis. So patient will have different color of iris and the affected eye will be hypochromic. Now you will tell me where we have studied heterochromia iritis before. It is an adverse drug reaction of which class of drug? Heterochromia iritis. It is a ADR, adverse drug reaction of which class of drug? Anti-glaucoma drug. Hint, latanoprost. Great, good. PG analogs. So H for heterochromia iritis. I stands for inferior eyelid. Inferior eyelid retraction. Sorry. Inferior eyelid infusion. This inferior eyelid elevation, remember, this is because of weakness of inferior tarsal muscle. Inferior tarsal muscle weakness will lead to inferior eyelid elevation. M stands for meiosis. So ICOPS, where H stands for, remember H stands for Horner syndrome. So here in Horner syndrome, you will get meiosis. A question which is asked, meiosis is because of, write down, meiosis is seen because of palsy of dilator pupillae. Meiosis is seen because of palsy of dilator pupillae muscle. Stands for anhidrosis. Anhidrosis means reduced ipsilateral sweating. Reduced ipsilateral sweating. Ptosis is drooping of upper eyelid, right? So this ptosis, important question, write down, is seen because of weakness of Mueller muscle. It is seen because of weakness of Mueller muscle, and write in bracket, but not LPS. Not LPS. What is LPS? Levator superioris. Levator palpebrae superioris. So ptosis is drooping of upper eyelid. It is seen because of weakness of Mueller muscle and not LPS, levator palpebrae superioris. This is also very important. L stands for loss of ciliospinal reflex, and E stands for inophthalmos. What is inophthalmos? Sunken eye. Eyeball is sunken eye. Sunken eyeball. So this is very important. Mnemonic, which you have to remember. Okay. Now next, write down color blindness. Next, write down color blindness. Color blindness. It can be congenital and it can also be acquired. If it is congenital, it is X-linked recessive. What do you mean by X-linked recessive? It means that males are affected. Males are affected more than females, and they skip generations. They skip generations means it passes from grandfather to grandson. Okay, so it is X-linked recessive. Whereas acquired form, write down acquired blue color blindness is blue-yellow type. Blue-yellow color blindness. This blue color yellow blindness is seen in macular diseases. Red-green color blindness. Red-green color blindness is seen okay. Now write down what is Anopia means blind. Color means the patient is red. Patient is red color blind. Treatment is not important for your exam point of view. Treatment of honors. So protanopia is red color blind. Deuteranopia. Deuteranopia is your green color blind. Tritanopia. Tritanopia is blind. Blue color blind. So we'll take a 10 minutes break and then we'll start again. 10 minutes break we'll take and then we'll start again.